Good morning and good afternoon to a few people, some places in the world. It is my great pleasure to invite you today to take part with us in an initiative together with EIT Health to look at the development of the European health data space, which is, of course, the big flagship initiative of the European Union in helping us build digital health throughout the EU. Working together with EIT Health and some of its partners, we're going to dive deep into some of the challenges of really making the European health data space able to deliver on the promises as set out in the policy documents. I'm going to hand over first now to Jan-Philipp Beck, the CEO of EIT Health, to give a little bit of background on what EIT Health is and why we've undertaken this exciting project. Jan-Philipp, over to you.
Thank you, Petra. Thank you very much, and good morning to everyone. Thank you for joining us this morning, and again, welcome to our event, which is entitled Learning from Innovators, Creating a Fit-for-Purpose European Health Data Space. Now, my name is Jan-Philipp Beck. I'm the CEO of EIT Health, and of course, I would like to welcome also all our speakers and contributors. Today, you will hear from all of them throughout this meeting when they will be introducing the use cases we have been focusing on. That's Liam English from Bluemetrix, Hans Hofstraat from Philips, Bieke van Gorp from FibriCheck, Peter Fasching and Bjoern Eskofier, both professors at the Friedrich-Alexander-Universität in Erlangen. And Petra, of course, great to have you here too. You are senior advisor at FTI, and fantastic to be working with you for this event. Now, it's also great that we have an international audience here today, and we'll be looking forward to also your questions and contributions during this event. Please make use of all the opportunities to ask questions, put them in the chat. Now, bear with me for just a very brief introduction. I want to tell you a little bit about EIT Health very shortly, and then also about the European health data space and the purpose of the project we've undertaken and the dialogue of today. Now, EIT Health is a vibrant community of some of the world's leading health innovators. It's backed by the European Union and the European Institute of Innovation and Technology. We are working across borders, and if you can bring on the slide, I plotted here all the locations where we have innovation and facilitation teams that connect our partners from business, from research, from education, healthcare delivery to answer some of Europe's biggest healthcare challenges. And we connect the needs of patients and citizens with our network to deliver real innovative solutions that can really transform healthcare and deliver positive patient-citizen impact. Now, we bring together the expertise from across the digital health spectrum. I brought with you slides that are very populated with the partners that we have in the network, if we can move to them. Partners coming from pharma, from medtech, digital, alongside, of course, academic partners and researchers, healthcare providers and payers, as well as also cities and regions with their innovation incubators. So we are essentially connecting strong innovation ecosystems in Europe. Now, our objective at EIT Health is always to support and empower innovators to overcome barriers. One of these barriers is, of course, funding, and we play a role in helping innovators to find funders, also private investors, partners, and ecosystems to help really to move from research to pilots and real proof point and then implementation. We also support innovators with understanding the regulatory landscape and compliance challenges of innovation and bringing innovative products to market. Now, scaling then across borders is very important. I think that digital and data-driven innovation really plays a key role in making healthcare more preventative, more proactive, to shift care to home and community settings. And of course, with this, hopefully also improve its quality and maybe also reduce its cost. I think digital health can bring about a paradigm shift. And remember, of course, that an old organization with new technology is just a costly old organization. So I think digital really has to deliver change and paradigm shifts. And for this, I think the European health data space, that is a major project of this commission, is of critical importance. As digital health is entering now a new era, with these new regulations being adopted at national and EU level, to develop a regulatory framework for digital health. And I think it's absolutely urgent that we move forward also to strengthen Europe's position globally, to make sure that we have digital health innovation also made in Europe that serves the needs of our population. Now, nationally, many countries are starting to adopt legislation to bring also digital therapeutics or new apps into reimbursable healthcare. A couple of weeks ago, we've had a very interesting conference in Berlin, the Digital Medicines Conference, where also the German government presented its fast track legislation, which I think is very innovative. And we are now also looking to support and facilitate the further dialogue around the uptake of such legislation in different European countries. Some of you may have heard also that France has made a very clear statement that it would like to adopt something like this, which could be amazing for Europe. Now, digital health is, of course, really heavily dependent on the capacity also of healthcare providers and researchers to access data for care provision, for policy development, and of course for research. So I think the European health data space is seen as one of these key tools to help eventually the sharing of data. It's foreseen in the Digital Governance Act, which is now in the final stages of negotiation and will be implemented through specific legislation to be brought forward next year. And Petra will give an overview on the EHDS, so the European Health Database space, in just a minute. Now, finally, what's the purpose of the project and the use cases that we will be presenting to you today and that we want to discuss with you? I think recognizing that new legislation is in development, we realized that many of our partners had encountered and struggled with several challenges, and we invited them to reflect on problems they had encountered and the issues they would like the EU policymakers to take into account when developing the EHDS. So we put a call out to partners, and I'm really grateful that those who are with us today responded with really very important and substantial cases. We worked closely with everyone to explore the challenges they had encountered, and that we would like the Commission and in due course also national legislators to really take into account when they're doing something about those. I'm grateful for the teams that have supported the work, and I'd also like to thank the European Commission for their availability to discuss these use cases already in a closed meeting back in July when we first brought them to the table. But we also wanted to bring this now to the more public forum to make sure that we can really discuss them with all of you, take your views and feedback, as it's really important to make the European health data space a success. Now, with that, I would like to hand back to Petra for a few more words of intro, and then I think we'll dive right into the use cases. Thank you very much for listening. Petra, back to you.
Thank you very much, Jan-Philipp, and thank you for your kind introduction to FTI Consulting. We are delighted to be working with EIT Health and with your amazing partners in taking this to the next step. So, Jan-Philipp, you talked a little bit about the European health data space, and I want to just share one slide. It's in fact a slide that has been developed by the European Commission. So if I could ask our background people, thank you very much, to share the one slide on the European health data space, because I just want to remind you what the objectives of the European health data space are. And I'll just continue talking while we wait for that slide to come up. But what I want to remind you about is that the European health data space is conceived of as having two main objectives. The first is to, and it's, you see it here in the dark Blue is to facilitate the use of data for the primary purpose of providing care to patients and for really making real the right under the GDPR for patients to have data portability, to be able to take their data from one provider to another, and through that to really drive the single market in health data and also in digital health. The secondary purpose, which will come a little later, but which is actually very much at the core of what we're talking about today, is the development of the European health data space as a space to reuse data for research and innovation and also for policy development. And we're going to be deep diving into that with some of our partners. The European Commission foresees 4 main pillars to make the European health data space function. And those are an appropriate legal and governance framework, and that is foreseen under the Digital Governance Act. And a lot of what we're doing here today is giving advice to the Commission on what needs to be addressed in that legal and governance framework to make the European health data space successful. But there are 3 other very important pillars around the quality of data. We'll deep dive into that as well, and particularly the concept of fair data, that is findable, accessible, interoperable, and reusable data. There is also the infrastructure that is needed, the cloud infrastructure for actually sharing the data. And then very importantly, the capacity building. And by that, we think about particularly the human resources, the data scientists that we need to really make this happen. And that's, of course, where EIT Health comes in as well, with its educational programs and helping build that next generation of data scientists and healthcare professionals who are enabled to really deal with digital health. As Jan-Philipp has said, and if we could move to the next slide, please. We have built this report that you have received the link to try and really dig into the reality of what happens when people develop digital health solutions. So I'm not going to talk any further about what we did. I'm going to let our partners speak for themselves. And what I'd like to do now is introduce the first of our partners to showcase their use case. I'm now going to hand over to Bieke van Gorp from the solution FibriCheck to talk around what FibriCheck is, why FibriCheck is already successful, and how FibriCheck could be even more successful if the European health data space were able to deliver everything it promises. Bieke, I'd like to hand over to you and you will walk through your slides. Thank you.
Thank you. Hello, everyone. My name is Bieke. I'm one of the co-founders of Compium, the company behind FibriCheck, as you'll see on the slides, a digital application to detect for cardiac arrhythmias. As you will see on the next one, FibriCheck or Compium is a Belgian company. We started the company back in 2014, so we are already quite some time in the market. Initially, we started with 4, but we grow into a team of almost 40 people, and we have all in-house capabilities. We have 2 business units, FibriCheck, a digital application to detect for cardiac arrhythmias, and Extra Horizon, a medical cloud infrastructure that we license to other companies that want to build their own medical application. For today, my focus will be on FibriCheck, where we have a clear mission. Our mission, as you'll see, has always been to revolutionize cardiology by offering device-agnostic solutions that you can just use on commercial devices everywhere, anytime, to timely detect for cardiac arrhythmias with the goal to prevent strokes and guide users to better healthcare outcomes. Our motivation from the beginning has been big, as the father of my co-founder suffered an unnecessary stroke due to undetected cardiac arrhythmias. Our product, as you will see next, is very simple. Actually, it's a mobile application that you can use on all commercial devices. From a user perspective, using it on a smartphone literally means he needs to put his finger on the camera of his smartphone for 60 seconds and we'll take care of the rest. FibriCheck can also be used on, for example, smartwatches, and there measurements can take place automatically at the wrist without the user needing to do anything, and it can be done everywhere, anytime. The impact FibriCheck is making is very, very big. Of course, we are certified as a medical device, but we worked very hard on our credibility. We have done an array of clinical studies, and of course, there are multiple publications. We have been accepted now by the medical community. Over 2,500 physicians are currently prescribing FibriCheck. And important, we make an impact for more than 700,000 users. And that can be different, preventing strokes, but also offering peace of mind. Being a digital application, FibriCheck can be used across different business models, as you will see next. So FibriCheck is both used in a doctor-to-patient setting, whereby doctors prescribe FibriCheck to their patients and follow up on their patients. But FibriCheck is also used in a P2C setting, where people prefer to use FibriCheck on themselves just to manage their chronic condition or to provide themselves a peace of mind. And lastly, FibriCheck is also used in a diagnostic as a service concept, where we are integrated with other applications. The customer journey depends, of course, on the model, but we'll focus here on the doctor-to-patient model. In that setting, a doctor always provides an access code to FibriCheck to the patients he wants to use FibriCheck. The access code can be provided physically, but also digitally. A user then needs to download the FibriCheck app, registers themselves, and in the registration process is requested to scan the code that he received from his doctor. So the link is made between himself and the doctor. A patient can then do an unlimited amount of measurements that are automatically transmitted to the physician as well. But of course, physicians are short in time, so we have an intelligent notification system as well to inform the doctor when action needs to be taken. I brought a couple of slides to give you some use cases. So as you will see on the next one, a concrete example is TeleCheck AF, a very, very successful program that we rolled out during the pandemic to assure the continuity and quality of care for our heart rhythm patients. Another one is the implementation of FibriCheck in the primary care settings. For example, in the UK, we attached the detection of cardiac arrhythmias towards the flu clinics. And actually, on my last slide, you see that a digital application of FibriCheck is so powerful and has so much impact to make that basically everything is possible and only imagination is the limitation. Thank you.
Thank you very much indeed, Bieke. That's a great overview of an amazing product. And what you've started to hint in that at already is the importance of collaboration between a company like yours, healthcare providers and patients. And we want to dig a little bit deeper into some of the challenges around collaboration. When we talk about the next product, which is DigiOnko, and I'm going to invite Professor Peter Fasching to describe the collaborative initiative that has led to DigiOnko and the successes that DigiOnko is already experiencing. Professor Fasching, over to you.
Yes, thank you very much. I'm very honored to speak in this community as a physician, as a doctor, where usually my responsibility is to take care of the patients. But over the last years, everybody, patients, doctors, industry, talked all about, how can we use this data in order to have a direct benefit for the patients, and how do we measure that? So in DigiOnko, in the case of breast cancer patients, because I'm a women's cancer specialist, we're building comprehensive digital care structure for cancer care to see how this data can be used to personalize medicine. And in breast cancer, this means the whole journey. Prevention, how do I prevent persons, citizens to get breast cancer? How do I do the early detection? How do I improve the treatment? And how do I avoid the relapse of breast cancer? So on the next slide, we get a little bit more insight into what that means. To focus on how do you actually take advantage of data for the patients, we chose several fields. And this gives you a good insight into the challenges and the thoughts that are behind DigiOnko. So besides the ideas to digitalize prevention, there's huge screening programs up and running all over Europe and all over the planet. But this has been very focused on the radiological image, but did not include, as we're seeing now, the implementation of lifestyle, the implementation of other diagnostic tests from saliva, from the urine, or from the blood. So how do you integrate all the possibilities to actually improve healthcare and to improve prevention? Because it's always the best if people don't get sick to start with. Then can you move as much of the healthcare provision from the hospital or the practice setting to the patient homes? That's a big field of concern here. And then which health apps are actually needed to improve healthcare? And finally, how to use this data. And that's one of the core aspects of DigiOnko, because collecting data can improve healthcare, and you can easily prove that it improves healthcare. But I am coming from drug development. We are dealing with substances being approved by European, by national authorities. And what are the measures for these authorities to decide whether something is good for the patient? They look very, very close at the data. They look very close at the data quality. And the data has to be provided in a certain format to prove that, in the case of cancer, less patients die, or more patients have a better quality of life with validated measurement methods. So everything that we do has to be measured in the light of, can we reduce deaths or can we improve quality of life? And the data has to have a very good quality and a certain data structure, which up to now might not have been taken care of so properly in some projects. Next one. So the journey is very complex, and Petra means prevention, early detection, treatment, and recurrence prevention. But we chose a real person that actually goes on this journey in her life with regard to breast cancer. Of course, men are not excluded from this project. 1 in 200 breast cancer cases is in men, but obviously it's a women's disease mainly. So we focus on Petra's journey here. And it starts, of course, with prevention. And if you take the opportunity not only to talk about breast cancer, you talk about health in general. So we're focusing on breast cancer, but also get the patient's awareness and education for other cancers and other diseases like stroke or heart attack, diabetes. So general information and the registration in an app to take care of the general health of the patient, focus on breast cancer. And then if the patient should be diagnosed with breast cancer, how do you capture all this data that you can carry it from A to B, from one hospital to the other? And importantly, how does the data structure have to be to have data that is comparable with regard to the quality with the data that is collected in clinical trials that lead to the approval of drugs with the quality standards that are up and running there? Because if I do a therapy recommendation or a recommendation concerning a health situation, I think the patients have a right that this is based on data that is at least as good as the data that comes from clinical trials. And then in the course of the journey, of course, all the results and all the data should be shared. And in the last slide, I showed you that all of this data should be analyzed with regard to machine learning. One of the most important messages is on this slide, because it's almost as busy as the slide that was shown by the CEO of EIT Health with all the collaboration partners. But these are the people and these institutions that are working only in DigiOnko together, centered around this task to get the data aligned in this high quality that outcome measures, value-based healthcare can be conducted in DigiOnko, and to get all of these people under one umbrella, that the patient knows what happens with the data, that the data is shared among these collaboration partners, to get the aspects of ethics and economics, of data protection, machine learning, aspects in the hospital setting, aspects that industry can benefit from this data, is a very, very big challenge. And I think this brings us to a summary of this project. And I hope that you understand there is now an effort to get the data together in a quality that it can be analyzed according to the standards that we do for other recommendations in medicine.
Thank you very much. That's amazing, and I love the way that you've used the acronym of Petra, and Petra as a real person, my name of course as well, to tell the story, because that's really where it's all at. It's that personalization element, and the EHDS will allow us to personalize more, and we'll come back to that when we deep dive into some of the questions with you. Now, we've just heard about an initiative that is a collaboration across different players and different partners in one country, but we now also want to talk to Hans Hofstraat, who's going to present the new SkyCare, which is an even deeper element of, or wider element, I should say, perhaps, of collaboration, and it explores some of the other challenges that arise when we collaborate to provide a different type of care. Hans, could I ask you to describe new SkyCare for us?
Yeah, thank you, Petra. I love to do that. And let's immediately move to the first slide. Now, New SkyCare is a project that has been funded and is receiving funding from EIT Health. So it's one of the examples of projects that benefit from this unique network that Jan-Philipp introduced, with partners from both the Netherlands and Sweden in this case. So exploring opportunities to bring digital solutions at a European scale. And Philips is obviously one of the partners in this project. Happy to represent also the rest of the team. Focus of New SkyCare is to really enable citizens, people, to increase their quality of life by equipping them with information that enables making a connection between the person, between the citizen and the healthcare professional, basically moving care from the hospital setting to the home, but making also the connection. Through doing that, citizens will become able to monitor their health and connect to professionals, enabled by an open platform that, and we will come to that later, facilitates sharing data, sharing information, but also enabling a connection between healthcare professional and a citizen when necessary. Leveraging advanced digital technologies to analyze, for instance, the quality of life or the medical condition of the person remotely. One element in there is to establish also, and one of the partners, Eurocross, has expertise in that, a pan-European medical service center that is able to support the patient and enable virtual care wherever the person may be. Now on the next slide, we move in a little bit more detail the partners that are working together. I already mentioned Eurocross, I already mentioned Philips providing the platform, the open platform, but of course, very importantly, also to connect to the care professional as well as to the patient or citizen, if you like, when maintaining a remote connection to the citizen, to the person, where the Erasmus Medical Center from Rotterdam in the Netherlands has been involved, focusing on diabetes type 2. Please stay on the previous slide, because I also would like to mention the Karolinska University Hospital in Stockholm that worked with us, focusing on heart failure as an application. And obviously both diabetes and heart failure are medical conditions that ideally are managed remotely and where people can live with good quality of life when managed appropriately, and when potential deterioration is anticipated and taken care of preventively. E-health devices are a centerpiece of the solution. So is the central platform where data are being integrated and used. Of course, this needs to be GDPR approved. and supports clinical decision rules and algorithms that automatically detect potential issues and may be taken into account by the service center. And of course, very important is to have the 24/7 availability of medical professionals. Let's go to the next slide. Here is the example of diabetes type 2. We have the measurement data. They're being integrated. They're being analyzed by rule engines, and trend data are being displayed to the healthcare professional so that action can be taken. Obviously, for heart failure, the same approach is implemented. I should add that the project leader of this project, Achmea, is one of the biggest healthcare insurers in Europe, also connected to Eurocross, so that we also implement this solution, taking into account the implementation from a healthcare economics point of view as well, which is extremely important, and we'll come back to that later on. Considerations that we have reported, and we will come back to that in more detail in the discussion, are particularly the implications of what we call the automation of care, how to do that in an appropriate way using the medical service center, but also to apply decision rules, to intervene when needed in an appropriate way, and some challenges around that in the discussion. I will come back to that. Regulatory classification being, of course, a very important consideration, and that, of course, also has consequences not only on the digital platform, but also on the devices to be used. A particular challenge we have been looking into is the opportunity of what we have called a bring your own device concept, which will, I would say, enable democratization or a wider spread of the solution and the challenges related to that. And we'll also come back to that in more detail. And that has also been described in more detail in the report we have created. With the approach, we really wanted to take an exploratory view across Europe, and the European health data space, of course, should in the end enable also the deployment of healthcare solutions in the European space, and happy to talk about the challenges and solutions in the discussions later on. Back to you, Petra.
Thank you so much, Hans. And we've got one more presentation, and then we're going to move into a more discursive mode where I'm going to invite our partners to answer some questions, but we're also very keen to answer questions that come from you in the meeting and from the floor. So don't forget that you can use the chat function to post some questions. Now, the 4 cases that we've seen so far are very much about patient-facing tools and systems. And of course, the patient is at the center of the healthcare system. But this needs to be supported by infrastructure. We can only share the data that has been described in the 3 cases we've seen so far if we have the right infrastructure and the capacity to do that. And now we're going to turn to a more infrastructure type of project. I'm going to ask Liam English to describe the Bluemetrix solution and how Bluemetrix and Bluemetrix style solutions can really help facilitate the sorts of things that we've seen in the previous 3 presentations. So Liam, very nice to have you with us. Do tell us a little bit about Bluemetrix.
Thanks, Petra. Nice to be here this morning. We're an Irish company. We're a little bit different, as you mentioned, to all of the previous speakers, in that we're specialists in the area of data, and we're experts in the area of building data lakes and data automation. That's what we do. We don't build any healthcare product. We work with healthcare providers to build data lakes for them so that they can use and they can access their data. Over the last 5-6 years, we've built over 400 data lakes across Europe, across Asia, all sectors: finance, automotive, retail, but also in the healthcare. So we've worked with companies like the NHS, organizations like the NHS, HSE, organizations like that. And typically, typically what we find when we look at the healthcare space, if you move on to the next slide, I'm just I'll explain it to you. When we look at building data lakes in the healthcare environment, this is typically what we find. We walk into people and we say, you know, what have you got? And they tell us that they've got data silos across primary, across secondary healthcare organizations. So you'll find different hospitals with different data warehouses, different data owners and data controllers across those organizations. And the patient data is typically spread across the different organizations. And where they want to get to is they want to build what we have shown here below the line. They want to build one view of the patient's data. They want to build it in a manner where it's controlled, where the data owners and the data controllers have access to the data and they manage how the data is used. But the data is usable by researchers, by clinicians, and by administrators, so that people can get outcomes from the data. That's typically what organizations want to build. What we do is what I've shown on the next slide. Where we come in is we basically enable that to happen. We work with the healthcare organization, we architect the environment, we help them design everything around the quality, the governance of their data. We build the governance framework for them. We help them implement their policies, bring them into a format where they can work with the system, and we provide data that's usable to clinicians and to researchers and administrators, so that people can get outcomes from the data and they can make use of that data. That's typically what we do. Like I said, we're quite different to everybody else you've got on your panel here today, but that's our area of expertise in the area of data automation and making data usable in a healthcare environment.
Excellent, thank you very much. I think we've had a really good introduction to, from Liam just now, to the baseline, the infrastructure we need, and three very different examples of how we can use data to really drive change in healthcare. I'm just going to take a moment now to introduce what we did in the report. So if I could just have the next slide, please. As Jan-Philipp has already mentioned, we had the pleasure of already presenting the report in a preliminary version to the European Commission and work with DG Sante in describing some of the challenges that we identified and to the suggested enablers. However, this is an ongoing work. As I said at the beginning, the European health data space is still being developed. Now is the time for us as a community to provide the information to the Commission of what is needed to make the European health data space successful. And that's why we invited these use case providers to work with us to present those challenges to the Commission. And we identified three big categories of challenges. They are presented here as a circle because they do all interlink. We can't slice and dice this in a way that they sit neatly in little boxes, but they do have distinct challenges. And that's what we're going to do now, is deep dive into each three of these areas. So we found challenges related to roles and relationships, roles held by healthcare providers and the relationships between healthcare providers and with patients, the rules and regulations that underpin how they interoperate, and then the practices and policies that have to be put in place, because we all know it doesn't start and end with a piece of law like the GDPR. That has to be implemented into everyday practice and policy. So that's what we're going to deep dive into now with our speakers. You've all had access to the report and you can read this in much more detail if you would like to. And of course, you'll be invited to not only post your questions, but also afterwards, if you'd like to share any further comments that you have around these three categories. So I'm now going to deep dive with our colleagues into the first set of challenges around roles and relationships. Thank you very much. And what we identified was three within that 3 particular issues: challenges around citizens' rights, particular challenges around consent to data use, but then also around data quality and data security. And I want to start off the discussion with our partners by focusing first on the experience of FibriCheck. And I wanted to ask you, Bieke, the FibriCheck solution is somewhat unusual in that you work both in a B2B relationship with a healthcare provider, but you also supply this directly to patients in a business to consumer relationship. What challenges has that created?
So thank you, Petra, for the question. Indeed, as FibriCheck is so flexible to be used in multiple contexts, this has different challenges, but a lot of challenges are on the data subject rights. So in a B2C context, we are of course the controller, and we interact for the different perspectives directly with the data subjects, who can also exercise their data subject rights directly with us. In a B2B context, it becomes then a little bit different and sometimes even very complex, because we have collaborations where we are a processor, but we have other collaborations where we are a joint controller. And their data subjects rights, certainly where we act as a processor, it's challenging to directly do, and they should go first towards the controller. But of course, from a data subjects, meaning the patient or the user, this complexity is not understandable, because from their perspective, their experience with FibriCheck is not significantly different. We offer the same transparency, the same quality, no matter whether they are a direct consumer, no matter whether we are used under the controllership of a hospital. So here we have had multiple challenges, leading often to frustrations from people in the past.
Interesting, lots of challenges and as you say, frustrations. And that's of course a huge challenge in itself, because if either clinicians or patients get frustrated, then they stop using the systems. And that's exactly what we want to avoid, because you've invested, the hospitals have invested, and we want people to make the best possible use of this. You alluded to particular challenges around consents, and Hans, I want to deep dive with you a little bit into the challenges that you've experienced with multiple consents being asked for. What problems has that posed for you?
Yeah, so and actually adding to Bieke's, I think, excellent introduction of the subject. I would like to take the person view, the citizen view, and because that is what we want to do with the new SkyCare solution, move, I would say, more ownership towards the person, towards the citizen. And in the solution that we were exploring, we do want to make the connection to the healthcare professional and also to the use of data generated that can help and support. And the service center, of course, is a third player that allows for 24/7 support. And effectively, this means that the citizen, the user, the person, has issues with respect to consent and providing consent to information to different players, at least that is the case at the moment. Which means that it's very confusing that for every use to be made of data that are being generated, this consent is necessary. On top of that, and we'll come to that, rules and regulations actually in the 2 countries where we were exploring this were quite different. So to bring that for the Eurocross type of solution at the European level is even more complicated. And that means that we really need to find a way to harmonize and create uniform consent approaches across Europe to enable effective use of solutions that basically bring care outside of the hospital into the home in a professional way.
Thank you. Liam, the issues that we've talked about so far already highlight some of the big challenges in design. The GDPR, of course, calls for data protection by default and by design. But we've already seen here that we've got challenges in how to design a data lake so that you actually can bring together these different challenges. Do you want to say a few words about that?
Sure. Petra, most of our experience, and like I said, we've built over 400 different data lakes. I'd say 80–90% of them have run into the same problems for the same reasons, which is that people build a data lake, they make a decision on the environment and the technology before they deal with the design issues. Our view very strongly would be, and even more so in healthcare, where data is so sensitive and you have so many multiple owners and controllers of the data, if you need to spend 3, 6, 9, 12 months at the start to design everything around the glossary of the data, the terminology that you're going to use, the outcomes, what your data sources are, how you're going to share it, how you're going to secure the data, that's what you need to do. If you do that properly, then you won't have an issue with building the data lake. And GDPR isn't an impediment here. If anything, it's good practice. It's guidance to good practices on building a data lake. Because our experience is that you can't easily retrofit governance or quality or security onto a data lake. You need to design it in from the very start. If you do that, technology is the implementation. That's the easy part of it. The difficult part is getting everybody in the room to agree what types of data we're talking about and how we're going to use them and share them. That would be our view on it and our experience of it.
Thank you very much. And what you've started to point towards there is the big challenge around trust in how people's policies are going to continue to be adhered to. Now, you're particularly interested in the trust in data sharing policies, but Professor Fasching, you're of course interested in ensuring the trust between healthcare professionals, that they can trust each other's data, that they can make decisions that they are personally happy with. Would you like to share a bit about the challenges that you've identified in DigiOnko about maintaining and building that trust between healthcare professionals as they work together? I think we're not hearing you. You may be on mute.
Oh, first of all, good to talk after Liam, because I can support everything that Liam just said. That would already increase the trust into the data. However, there might be a little bit more to it. If we are getting drugs approved, and we're talking a lot about drug approval with the COVID vaccine these days, but any drug, if it's approved, there is data that is reviewed, and we do know how this data is collected and how this data is analyzed. And that's something that we can trust. Let's take this as a gold standard. And with the spirit of pioneers and the motivation of pioneers that's right now in the digital field, many times if you read publications, you do not really know how was this data collected. So how, on top of what Liam just said, is we don't only have to have a good idea about the data structure and about an agreement what the outcomes are and what the variables are, we also need some standards in how this data is collected with regard to data completeness and how this data is analyzed. Because in 10 years from now, we're going to ask ourselves, what has been practice changing? And I do not mean that the patients then have a smart device with which they can share their data. Of course, that's practice changing. I mean, what practice changing knowledge was produced that changes medical outcome, that leads to less deaths, that leads to an improved quality of life. And then it won't be enough anymore to say, okay, we have a good data structure, we do know the outcomes, but then we have to connect the real world. How is this data collected? To these data pools, to these data lakes, and look for a completeness in the way how we prospectively collect this data. And this, if we get there in the next few years, I'm convinced that the digital data and the digital data community is to be as trusted as we trust the data that is generated in the context of clinical trials that leads to drug approval.
Great, thank you very much. I want to build on something that you've just alluded to in your answer, and I want to draw in one of your colleagues, because we also have one of your colleagues, Bjoern Eskofier, with us, who's you're on the patient-facing clinical side. Bjoern, you're more on the technical side of DigiOnko. One of the questions that we've had from the floor is, what about the integration of technical standards like ICD-11, SNOMED CT, EN 13606, and there are many others. And actually, when we talk about the Petra case, we also have the new ISO standard for apps that has just been introduced. What is your experience of integrating, Bjoern? What's your experience of integrating technical standards and how that can help with building the trust? And then Liam, you may have a thought about technical standards as well. But Bjoern, I'd like to introduce you, please.
Yeah, thank you very much, Petra, and thanks for the great question, which has also been taken up from the floor. It's always a two-phase thing to talk about standards, of course. So on the one hand, you have something you can rely on. On the other hand, if you use a certain standard, then others will probably don't like the standard, and then you cannot interact with each other. So we in DigiOnko don't really have this problem, because we can define our own ecosystem that we can work on. So this is a research project currently, which will hopefully end up in a digital tool that can support real patients. That's the idea. And as long as we define our own standards inside this research ecosystem, and later, hopefully product and or digital service, we are good. But I guess for the larger EHDS discussion, it is very important that we can rely on certain standards. EHDS needs to be open to a couple of ideas, so there cannot be just one single standard that, so to say, rules them all, because otherwise we would shut out maybe other interesting ideas. So there needs to be a so-called set of standards that can operate within the EHDS, and certainly EIT Health can play an important role in mediating the discussion around that, and then finally selecting the set of standards that will define the EHDS.
Excellent, thank you very much. And I think, Liam, you wanted to maybe mention some of the technical standards that you work with.
Yeah, well, yes, we've worked with SNOMED and standards like that across the healthcare sector, and excellent. They're excellent tools, but they're tools, and really it's garbage in, garbage out. It's how much time you spend in the design of these things, how much time you put into the implementation of this. And if you spend time in the design and the implementation, yes, they can really help, and they can help with the quality of your data in the data lake. Peter mentioned, and Bjoern as well, a little bit about standards, and I think in relation to devices and in relation to collection. Now, that's not our area of expertise. We basically get the data when it comes into the data lake. But obviously, if there are standards available that govern what the quality of the data is, what types of data, what formats they take, then that simplifies the integration of that data from devices into the data lake, and it will make it a lot easier for people to collect data and share data. So I'm all in favor of standards, and anything the EHS can do to help there, I think is a positive thing.
Thank you very much. So that's Hans, please go ahead.
Yeah, I would really like to add to that, because standardization, you mentioned before the FAIR principle, and the fact that we need to make data interoperable and reusable is part of that, and their standards are needed, and agreement. So also devices talking to each other, solutions talking to each other, FIRE HL7 being very important, but also interoperability between data. And there we have the Personal Healthcare Alliance, the Continua Alliance that is working on that on the device side, but also in terms of reuse of data and interoperability, where SNOMED CT, but also ICD-11 and other standards. But in the end, the field of healthcare is developing, and Professor Fasching alluded to that. So these standards, these data languages, if you like, they also evolve, and it is a matter of, I would say, continuously working together and improving on these standards and mapping data in a appropriate way to enable the effective use of data and digital solutions.
Thank you very much. So we've got there a very clear call out to the Commission on supporting the adoption and the development of standards. And thank you for that question from the floor. I hope that answered your question. Now, we have another half hour with you, so we're going to continue by looking at the next set of challenges that were identified. And they're here on your screen now. They're to do very much with the rules and regulations. And I want to say that whilst the rules and regulations around how the European data space is going to function are really important, they're not the only thing that is relevant, but they are super important, which is why we're going to spend a little bit of time talking about some of the challenges that have been identified. And they fall into, again, three broad categories. One is particularly around the legacy data, systems. Whilst the GDPR is now not such a new piece of legislation, it had to fit in with much legacy legislation, but also the way in which hospitals are run, the way in which healthcare systems and healthcare funds work is a matter of national subsidiarity. It happens at national level law, and we have this constant complexity of interaction between European level law, national level law, old law and new law, and this creates a lot of confusion, particularly when we come to the question of reusing data for research purposes and the many different legal bases that exist for that, both within EU level legislation like the GDPR and in national level legislation. So I want to explore some of these issues with our partners again. And I'd like to begin by asking Bjoern for you to share a little bit about a particular challenge you experienced in DigiOnko around a clash between EU level and national level and even regional level law. Bjoern, can I ask you to talk about what you experienced?
Yeah, so far in DigiOnko, we are not really clashing with European or German laws, but I can report on this outside the DigiOnko scope. So within DigiOnko and a lot of the other projects we do in our specific setting in Erlangen, which is two EIT Health partners, actually, the University Hospital and the university. They are two different legal entities. We have certain, let's say, challenges in operating on our own university hospitals' data. And the rules for that stem from local legislation, which is the Free State of Bavaria law that states that university hospital data or hospital data in general can only be accessed and operated on within the premises of the university hospital. So imagine the case of an individual PhD student wanting to work on data that is hired by the university. This already poses a couple of real-world challenges. And then if you think further about interoperable data even within the same research project, even benefiting patients, we are facing multiple challenges from this legislation alone. And now we are, as I said, only thinking about one research project within the scope of funding by the Free State of Bavaria. So we can talk to the individual parties that are responsible for legislation and at least try to find solutions for this. But if you are talking now about a German or even a European interoperable health data space, there needs to be, and this is really a call out for EHDS to also form the legislation needed around it, because all Europeans need to have a legislation framework that allows us to do research, to also help patients, to treat patients better, and to create a digital ecosystem around this that allows for these future medical use cases. And just to end with, we are trying to initiate at least technical frameworks, but also speak with legislatory entities around this. So together with Petra Fasching and others in our German ecosystem, we've won a project by the German Ministry of Economy, which creates so to say, German version of the European health data space on the basis of Gaia-X. So this is another project that certainly will help us push forward the technical standards, but also the legislatory environment to make our ideas come true.
Thank you very much. And you've pointed out a particular challenge there. I'm sure members of the audience will have experienced this in their home countries as well. But it's not only about clashes, it's also about time lags and legislation catching up. And Hans, I know you've experienced some of this in new SkyCare. Share a little bit about your problem there.
Yeah, really, thank you, Petra, for giving the opportunity and adding to Bjoern, because I recognize his input very well. What we covered is clashes in between, clashes. The need to get to agreements, agreements on data use being quite different. So GDPR, of course, is a framework, but the interpretation of GDPR, for instance, in Sweden and in the Netherlands is different, and also the different parties, say the clinical party, the insurance and service provider, and us as company. Also coming with different perspectives in how to arrange for access to data, and really also to some extent, if you like, discovering how to do that in an appropriate way within the GDPR has led to quite some challenges in terms of timing. And I think a call out, but I'm repeating a bit of Björn's claim, I would say EHDS can really help to create that European framework and make sure that European member states and even I would say Bundesländer in Germany, as I just learned, adopt I would say a similar way of dealing with access to data, privacy issues. So at least that is harmonized and we're all starting from the same level of entry. I think that would already help quite a bit, and also an openness towards supporting digital health solutions. Gaia-X was mentioned also by the previous speaker. Now we're working on focusing on HealthX, the health implementation of Gaia-X that together with EHDS can really help to move that forward. But also important is to do the same with the medical device regulation, and because if we want to get and guarantee access to data, is also the medical device regulation that needs to evolve. And I think an integration and interaction with the European Commission on the regulatory side as well as on the data access side is needed in order to move forward with digital health solutions.
Excellent, thank you. So a big call out there to the Commission to facilitate good cooperation between the European member states as we move forward with the EHDS, because it's not only about EU level legislation, but, and then as Hans has just pointed out to us, there are of course a number of EU legislations that are relevant, including the medical device regulation. Now, Bieke, I want to come to you a little bit to go back to one of the issues that we said at the very beginning the EHDS is about. It as well as being about providing care to patients, and of course your solution does that on a day-to-day basis, it's also about being able to use data for research purposes. FibriCheck is of course a product provider, but you can only improve your product if you can do further research. So tell us about some of the problems that you've encountered in reusing data for research purposes.
Yeah, and thank you, Petra. For this one, I can second a lot of Hans has been stating, and we have a lot of the similar challenges. I think with respect to research purposes, where we are most struggling with, and often because of uncertainty and the difference between the different member states, is how to use the wealth of data that FibriCheck has for adjacent research purposes, like comorbidities and other elements to in the end learn more and improve the healthcare aspect of the users. And because it is so challenging to reuse data, I need to admit that most of the time it's not done, and we limit ourselves to pure clinical studies with informed consent, in the end very like focused, without using the wealth of data that we have for other purposes. And as indicated, it's not because maybe it's not possible, it's more because there is so much uncertainty about it that it takes so much time to arrange everything that it's often preferred not being done. So I believe what could maybe be helpful is a kind of general consent for research purposes, as I do feel based on our user base that they are very positive to have their data for research purposes, of course, when done by research institutes. So they might be sensitive on other organizations, which I could understand. But I think thinking along these lines, there might be some possibilities that would or might help us further.
Thank you very much. I just want to remind our audience that you're welcome to post questions. We were able to dig a little bit deeper onto standards, which we haven't planned to do on the basis of one of your questions. So don't hesitate to ask some questions. But Liam, I wanted to come back to you on some of the issues that Bieke has just raised. So Bieke talked about some of the problems in consent. And of course, there is the practical challenge of asking patients for consent, but there's also a challenge in that you may have different interpretations of consent, different consent policies that operate in different hospitals or different research environments. And if you're creating a data lake like you are, and like the EHDS is going to be, how do you manage all those different types of consent policies? So how do we marry up the practical policy challenges with the overarching legislation? What's your experience been there, Liam?
It's very difficult because obviously the value of the data in the data lake, it increases with the number of sources it comes from. So if you've got data from 5 sources, and you've got data from 50 sources, the data from 50 sources is much more valuable than it is from 5. The problem you have is typically in healthcare, each data source has a different data policy and they're created independently, not through any different standards or any structures. So what we try to do is, if we're bringing in data from multiple sources, we try to come up with a scoring or a ranking system for the policy so that we can compare policies. Because what happens is, data, when we bring it together in a data lake, we usually have 1 or 2 base repositories of the data, and a record in that repository could be governed by 40, 50 different policies. So before we can give access to it, if we have to compare it against 50 policies, it really complicates the issue. So what we try to do is, we agree with the data owners what's a ranking system around access, around security, and then we score the policies accordingly. But if that was standardized, and this is where I think the EHDS could come in, if that was standardized, it would simplify dramatically the integration of multiple data sources into a data lake. And I mean, go back to Peter's presentation earlier on, where he showed at the very end, I think, Peter, you had about 20, 25 different partners where you were working with, and each one of those will have multiple different data sets. You could potentially, in that scenario, have anywhere from 50 to 100 different policies governing all of that data. Then really, in order to be able to make that data integratable and available, we need some type of standardization system to combine policies. And I think that's the most critical standardization issue that we need to address today to allow healthcare data to be combined, because it's not like financial data. It's much more distributed with much more diverse ownership of it.
Thank you very much, Liam. And with that, you've actually taken us beautifully into the last set of challenges, which is around policies and practices. And I'm going to come back to you in a moment for you to give you the opportunity just to expand a little bit more on what Bluemetrix is doing to address these challenges. But I do first want to put up the slide, please, with the issues that we identified around policies and practices, because actually this is where we identified the biggest number of challenges. We looked back to some of the issues that we started to discuss at the beginning around building trust between patients and healthcare providers. It has to be earned and it has to be maintained, but it has to be reinforced through practical policies and practice practical practices. It's a tautology, but I think you get what I mean. And one of the big challenges that we identified there is the legal certainty. And that is, of course, also within what we've already described is understanding which law applies when and where. Where we then start to move outside the legislation like GDPR and the legislation that we see as fundamental to the European health data space is around liability for clinical decisions. Right at the beginning, Professor Fasching spoke to us about the need for cooperation between doctors and to trust the data provided from one source to be used by a doctor in another source, in another healthcare environment. And we've also identified huge issues around process interoperability. Liam started to unpack that a little bit and started to indicate that one of the ways of dealing that is with standardized processes. And standardized processes, of course, demand standardized data and data interoperability. And we've discussed, on the basis of the question from the audience, some of the data standards that are relevant. And of course, one of the big challenges that we still have is that while there are many data interoperability standards around, they're not necessarily used. But I want to go back, Liam, to you to just give you the opportunities to say a few more words, and we are coming to the end of our session, about those challenges for creating an environment where different healthcare providers can know and understand and feel confident that they are not breaching their own internal policies when sharing data in a data lake or when accessing data from a data lake. Do you want to just say a few more words about that?
Thanks, Petra. Yeah, I mean, our experience in this is that there's a number of different factors you have to look into here. One is security. Across different organizations have different security practices. So the ICT department in one hospital will have a different set of policies to another. So you need to coordinate security across organizations that are sharing data. You need to agree in relation to how you encrypt the data and how you secure the data. Is it tokenized? What level of tokenization? And so on. So basically, there's technical issues, and most of the technical issues can be agreed and can be sorted between the organizations if the organization numbers are not very large. The biggest issues, again, I was alluding to it earlier on, come back to policies. And because ultimately it comes back to data owners, data controllers, who are legally responsible for the data that's in their care. And that comes back to what their policies say and what type of detail is in their policies. And if you want to make data shareable, you have to have some type of guardrails, scoring system, whatever you want to call it, which allows people to say, my policy sits in this level of security and this level of access. Therefore, if somebody requires this level of access to it, I can give it to them. If they require higher or lower, we can't give it to them. And I think that's the most, to me, from a data lake implementation standpoint, it's the biggest barrier today to building rich data lakes, and it's the biggest barrier to allowing companies and organizations make their data available for integration to the data lakes.
Thank you very much. Thank you very much for sharing that. Bieke, FibriCheck, we've already said there are already some particular challenges about legal certainty when you're working across different types of care providers and in different types of relationships. what are the challenges that you've experienced as a company in overcoming legal certainty, and perhaps some of the reluctance of the partners that you work with? And what would you like the EHDS to do to change that?
Do you mean now on a data subject principle or on the legal ground principle, Petra?
I meant more on the legal basis principle, but as you wish.
I'm not sure that I'm in the right position to answer this.
Well, then, sorry. What I wanted you to mention is some of the challenges that you have when you're moving between a B2B relationship and a B2C relationship, for your partners to know where you stand. So, for example, sometimes you're a data controller, sometimes you're a data processor, and you change between of those, and that creates challenges for you, I believe.
No, absolutely. Yeah, no, that's clear. In some of the challenges that we have there is with respect to legal grounds aspect. So when we are in a B2C context, we of course always ask explicit consents towards the users for different perspectives, both for using the data for their care, and to use their data in an anonymized format, completely anonymized, for further research purposes. When we are a processor for a hospital setting, of course, principally, we don't need to ask the explicit consent, as we build on the medical legal ground of the hospital. From a Fibrocheck perspective, by the way, we do this just for transparency and clarifications towards the user, that is very clear to what they use the data is used for. But of course, then, the grounds are different, which has then different impacts and different relationships with data subjects' rights. So I would say that we always struggle around with the same challenges as people can move from one to the other. And we even have people that use FibriCheck along the complete patient life cycle, first in a B2C context, then in a B2B context, and then again in a B2C context. And this creates, a set of challenges, both with respect to legal grounds, with respect to data subject rights, with respect to which parts of the data can be further used for research purposes. So it's a myriad of challenges that this provides.
Thank you very much. And that's, of course, where the sort of solution that Liam described, and making those policies really visible to everybody and interoperable and labeled, meta-labeling of the policies, if you like, can really become part of the solution. As I said at the beginning, the policies and practices part is really about building trust. And whether it's building trust between, as Bieke just pointed out, data processors and data controllers, or researchers and healthcare professionals, it is, of course, also about building trust with patients. Professor Fasching, I'd like to come back to you on that, because amongst this group, you're the person who has the most direct contact with patients. Patients need to trust a new system like DigiOnko. They need to trust that their data is safe, but they also need to trust that you are using the data, that you are able to treat them in a safe way using a new solution like DigiOnko. What particular challenges have you faced in terms of
We're still online. I think we lost Petra. Is this correct?
Yes, it's correct. Yes.
Yeah.
I think Petra wanted to ask me about the patient's trust in what we're doing. I think the most important message is there is lots of trust. You know, what the patients think, what we're doing with the data. The vast majority of patients that have a disease, that get into healthcare because they have a problem, they don't think that we're doing anything with the data that shouldn't be done with the data. So they're actually grateful for that computer scientists and excellent machine learning experts like Bjoern Eskofier, they're working in the background with the data in order to improve the treatment of the disease that they think that needs to be treated and that they have problems with. However, of course, even patients that are very giving with regard to their data, they might not want anybody to know about their newly discovered cognitive dysfunctions through the chemotherapy. Or what if there's a vast change in sexual function in endocrine treatments? What about there's a financial impact of a disease? There might be partial aspects of the data that is collected they don't want to share with other people. So there have to be options for the patients to opt in and to opt out. What data do they donate and what data is to be used? And there's a good message that is attached to that as well. What we were talking about here, I try to categorize into data that is used to improve practicability of healthcare. Life becomes easier if everything is electronic. So I'm grateful, patients are grateful. Then there's a second aspect to the EHDS, quality control. You can do quality control measures where the healthcare is delivered appropriately. And there's a third point that some of us were talking about. I think it's innovation. And there's so much good news about innovation because up to now, we only needed 1,000 to 5,000 patients in order to generate practice-changing data. If the question was defined very well, if there was a hypothesis and the data was collected in a very high data quality. So if you didn't ask the patient, can I use this data? It's not that difficult to collect data from 1,000 to 5,000 specific patients. So that's the good news associated with it. So I think we have lots of room to work with the patients. They trust us, but they also want some data maybe not to be used for an analysis. So we have to give them the possibility to protect that. And first of all, everybody of us has been a patient at this point. Would be a miracle if anybody in this web conference wouldn't have been a patient at some point. We want to know what's happening with the data. So transparency, prospective information of the patient is what lets us move forward. And I think there's no need to be concerned that if patients say, I don't want to be part of this data collection, or I don't want this or that part of the data to be used, I don't think in the next 10 years, anything of that will impact us because there's so many low-hanging fruits right now with data science in medicine that we can really try to get this improved, what we're doing here.
Thank you for ending your point on a very positive note there. That's we've been talking a lot about challenges. It's really important to highlight those positive points.
But we need you to overcome all of these hurdles that are still there because it's right in front of our eyes, these improvements and innovations. We just have to collect them. So we really have to put a little effort into getting there really soon because it's right hanging in front of our eyes. We want to get there.
Thank you. That's a great image to end with. Hans, I'm going to just give you the last word very briefly before we close, because you have talked at the very beginning about the idea of a bring your own device scenario in the healthcare setting, and that does create a few challenges for you. So I just want you to say something about that, but perhaps you can talk positively as well about why BYO is such a big opportunity. Thank you.
Yeah, quality of data starts with the quality of the device. And I already mentioned the medical device regulation that should be enabling that, and also approaches to ensure trustworthiness of data, which can be done in all kinds of ways, also using digital solutions in terms of calibration and measurement. Very important, of course, is to know what is the scope of the solution that is enabled, and to be able to identify the working range. So in terms of developing solutions, it's about the quality of the device, the quality of the data, but also the quality of the advice and the information that is being presented, which does require also appropriate risk analysis. But I think for all these challenges, if we interact with the European Health Data Space, as well as with the EMA, the regulatory authorities, we will be able to solve these issues and leverage digital solutions for the benefit of health in Europe.
Thank you very much. So I think what we've done now is really demonstrated with our 4 amazing use cases As Professor Fasching said, there are some amazing fruits out there. They're juicy, they're ready, they're ripe. We just need to be able to grab them. There is still work to be done. The European Health Data Space does provide a huge opportunity to make all of this come together. But there are big challenges that we need to work with across several sectors. And we need to ensure that we have the solutions in groups that, like Liam's group in Bluemetrix is working on, that we bring the data scientists like Bjoern to work in close collaboration with the healthcare professionals like Petra, that the new SMEs like Bieke's group can really play part of that new ecosystem, because it isn't just all about big hospitals, because we are trying to enable patients with their own devices, as new SkyCare has shown, to be part of the system, to build the new ecosystem of healthcare where the patient is empowered to be part of their own healthcare decision making, and really be part of the journey. And as DigiOnko has shown, and FibriCheck has shown, to be part of a journey that really is based in prevention. And of course, in new SkyCare as well, you're dealing a lot with diabetes. This is all about prevention, preventing people to moving on to the exacerbation of diabetes. I'm really pleased with what we've been able to do here today and demonstrate to our audience that there are some amazing solutions out there. And to reinforce our message back to the European Commission that it's going to take a strong European health data space to really make it come to fruition quickly, safely, in a user-friendly way that builds trust for everyone. I'd just like to end by asking whether anybody would like to say a couple of closing words. Jan-Philipp from EIT Health, I'm not sure if you're still with us and able just to say a few closing words, because this was, of course, a product of your baby, EIT Health. Jan-Philipp?
Thank you, Petra. I'm both willing and able, with minus 30 seconds left on the clock, but I would not want to go before thanking everyone for contributing, thanking everyone in the audience for being with us. Thank you. I think the discussion has been extremely rich. Just like 20 seconds takeaways for me are really a call to the Commission also to be bold, potentially on standards and harmonization. I think that call has been made, but it doesn't stop there. I think enabling digital ecosystems will also require a good alignment of member state legislation, and also where they maintain having competence. I think this is also has been mentioned clearly and will be important. I also believe that it will be key to, as many said, to crack the nuts around implementing better mechanisms for consent, maybe dynamic consent. And I think the call that Petra Fasching has made on giving patients the possibility to also make well-informed choices in that process is very, very important. And finally, Bieke, I like very much what you said about that many opportunities that we may have today, that you have today, are not used because so much uncertainty also still remaining in the maybe also legal technical implications. So I think if the EHDS can help to reduce uncertainty, and by that maybe also help strengthen some of that optimism that we also heard in the call, I think that would be great. Optimism to unleash then more dynamic to innovate and to foster data-driven innovation in Europe. So with that, we'll continue the dialogue with the Commission. Thank you all for contributing. And I wish everyone also fantastic success with the continuing projects. I think they are really, really important to improve outcomes for patients, and also hopefully help our healthcare system transform in a positive way. Thank you very much.
Thank you.
Thank you, everybody. Thank you to our partners, and thank you to the audience for being with us.
Thank you, everyone. Take care. Thank you. Bye-bye.
Bye.